So next I invite Dr. Veena Viswam. She will be talking on selective laser trabeculoplasty. Dr. Veena is a glaucoma consultant working at Amardeep Eye Care.
Good morning, everyone. First of all, I thank Nimita for giving me this opportunity to present here. So I'll be talking about selective laser trabeculoplasty. I know that many of you are not aware of this procedure. This is a recent procedure. It started in the early 2000s, and still many of the hospitals are have just started using it. And so I would like to give you an idea about what I am doing. We have been doing it since the past 2 years, and our experience and basics about how the procedure should be done, what all you should be doing, is what my intention is to speak here. So, as the name indicates, it is a selective laser procedure. It improves trabecular meshwork damage because the laser acts on the melanocytes of the trabecular meshwork. When the laser falls, the melanocytes absorbs the energy, and only the melanocytes are affected during the procedure. So, to see the trabecular meshwork, the angle should be open, right? So, a good open angle is the need for a case whom we select for trabecular selective laser trabeculoplasty. So, this procedure can be done in POAG patients, pseudo exfoliation patients. In our experience, have good results. Pigmentary glaucoma, because of increased number of melanocytes, maybe they also respond very well. Then in normal tension glaucoma and ocular hypertension also, nowadays selective laser trabeculoplasty is being used. So as I mentioned, a good gonioscopy is mandatory, and we have to see all the angle structures. The angle should be wide open. Otherwise, whatever photo disruption may cause a peripheral anterior synechial formation later. Okay. So coming to the procedure, we have to do a gonioscopy. So topical anesthesia, in my routine procedures, I put topical anesthetic before 2 minutes because I want my patient to be still during my procedure. So I would advise you to do the same, and always mark the eye. Mark the eye. This is a small procedure. You may feel that the patient is not having any problem, like no pain or bleeding or anything, but still understand the importance of marking the eye and taking the consent. My previous speaker, she has beautifully given you an idea of what consent should be taken. So even the Malayalam print which she showed is very good. I would like to get it from her, because we usually give an English consent and it was beautifully written. So thank you for that. Now coming to the procedure, the frequency is 532 nanometers. The same Nd:YAG laser is frequency doubled and used in this procedure. The spot size is larger. You know that in argon laser, the spot size is very small. We have to focus. But in this is a comparatively less skill only is required. This is not a procedure which requires lot of skill. So the spot size is large. On the trabecular meshwork, you can focus. Okay, it is a continuous sort of, we give the spots in a continuous sort of way. The pulse duration is 3 nanoseconds. So the thermal relaxation time of the tissue is more than this. So there won't be any burns happening at the area. Then the energy is 4.4 to 1.2 millijoules. In my experience, within 1.4 to 0.6 itself, this champagne bubbles, we won't see any change there. Like in iridotomy, we see what is happening. But here, there won't be any visible change. The only visible change we see are bubbles coming. So that is called champagne bubble appearance. So I'll show a video. See, this is how we do. We focus, we try to make the spot clear on the trabecular meshwork, and continuously, without overlapping, continuous shots are given. Can you see the small bubbles coming? Those are called the champagne bubbles. Okay. This is taken as the endpoint. And when the champagne bubbles come, we reduce the energy a little bit and then give. So champagne bubble is taken as the endpoint. Usually I select the inferior angles first because it is the wider angle. It is the widest angle in any eye. So for easy doing, I select the inferior angles first. So you have to focus on the superior mirror and do continuously. 25 shots each quadrant. So 180 degrees, you give 50 shots. When you come to the edges of the mirror, it is difficult because focusing is difficult. You have to get a skill to tilt the mirror and look at the side and give the shots. Then these are the small practical difficulties. Some studies say that champagne bubble formation is a false endpoint because there is not much histopathological changes happening there. Then this is a word about the machine I already mentioned. It is a Q-switch frequency double laser. The mechanism is not photocoagulation, it is photo disruption of the melanocytes. Now always record what you are doing because in an iridotomy you can see what you have done. After 1 week when you call the patient, you won't remember which angle you have given. So always draw a picture, draw a line and mark the quadrants and draw what you have done. Then consent, I already mentioned, small, there won't be much bleeding, there won't be much inflammation, but mention all that in your consent form. Mention that there won't be much reduction of IOP. Mention that there may be hike in IOP. Okay. So why are you doing the procedure? Talk to the patient. That what to expect. There won't be any dramatic change. Repeat the procedure if it is needed. So, and you may need medication later. That also you should tell the patient. A practical way of dealing with it is tell the patient that you may be able to stop one medicine. Then the patient will be expecting that only. You may be able to stop one medicine after this procedure. Then post-treatment, how do you know small variations in IOP? You have to be very clear how much IOP has come down. So applanation tonometer is my way to go. And I use the same tonometer. We have so many applanation tonometers, but I take it in one tonometer before and after the procedure. You can mark the tonometer as a tonometer 1, 2 or something. If you are taking RT, mention that. If you are taking NCT before and after, mention that and record everything. Then I do it after 30 minutes, then after 1 week, 1 month, 3 months and 6 months. We have 2 years data and many a times there will be variations which should be recorded properly. Then there may be examiner bias also. Always the same examiner better to record because for some people wider Myers and will be their endpoints. For some people the thin Myers will be their way of taking the IOP. So if the Myers are wider, you know that the IOP will be falsely high. And if the Myers are thinner, you know that the IOP will be falsely low. For different examiners, it's not good to take for the same patient for follow-up for this procedure. So post-operatively also, I don't give steroids because steroids may slowly increase the IOP. So I give nepafenec eye drops. There will be only minimal inflammation. And I think that is enough. For all my patients, I have never had an issue with this. Then best results are in treatment-naive patients. Delayed response is very common in SLT. So many patients who had a hike in IOP, after 6 months or so, when we check it again, the IOP has drastically come down. So be patient, it will come down. In my experience, SLT is very, very useful in your treatment of primary open angle glaucoma. Don't use it in narrow angles like NVG, angle recession also, don't use it. And the most important advantage is that it is repeatable. You can do it again and again and it's less costly and patient compliance is better. Disadvantages, sometimes you have to be patient. Sometimes it won't work when you want it to. Then so many studies have also, that light study, NICE guidelines, all advocates the use of this laser. So in my experience, SLT is a very good weapon in your armamentarium for treating glaucoma. You can start using it. Okay, thank you.
Thank you, Dr. Veena. Thank you, Roshna. I forgot to mention.